Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. So this is the 24th presentation in this series of 30. We're going to be talking about effects of sleep on breathing, third part. This is the Great Adventure, Pediatric Pulmonary Physiology. And as you can see, we're moving along. We want to approach this with the enthusiasm of a kid in a candy shop. So we've talked about the respiratory balance with respect to sleep. You now know that sleep decreases central drive and also can decrease the effectiveness of ventilatory muscle power. So sleep does have a profound effect on breathing and the ability to breathe. Today we're going to talk about obstructive sleep apnea. We're going to answer the question, what about supplemental oxygen for the treatment of obstructive sleep apnea? Respiratory control on obstructive sleep apnea, and then a summary of the effects of sleep on breathing. So this really is going to focus more on physiologic aspects of obstructive sleep apnea. It is obviously still worth learning about obstructive sleep apnea from the point of view of sleep medicine physicians. So, obstructive sleep apnea. Extrapulmonary airway obstruction, remember, is primarily an inspiratory phenomenon. That is, one can have an obstruction here. In order to overcome that, you have to draw more negative intrathoracic pressure while you're breathing, such that the pressure inside the airway can be less than the pressure outside the airway, resulting in collapse somewhere along this airway outside the chest cavity, causing an inspiratory airway obstruction. During expiration, you're actually generating a positive pressure inside the airway to bypass this obstruction, so that extrapulmonary airway obstruction is not an expiratory phenomenon. It's an inspiratory phenomenon, and you all know you hear stridor, which is an inspiratory problem. So when you're breathing during sleep, this is an example of a normal situation. So the airway is open, right? And specifically around here where the tongue could potentially go against the back of the airway, for example. It is open and breathing can occur. With obstructive sleep apnea, what happens is that this airway becomes occluded. It could be the tongue falling back, or it could be collapse of other soft tissues in the airway due to decreased skeletal muscle tone. And remember, increased inspiratory effort is going to just draw these tissues together with increased pressure. In order to keep the airway open, you need a large airway, you need increased amounts of upper airway skeletal muscle tone, and decreased inspiratory force. To close the airway, you need a small airway, decreased skeletal muscle tone, and/or an increase in the amount of inspiratory force. So these are the dynamics, if you will, that determine upper airway patency or if it's closed. So this is a hypnogram, which basically shows over the night when severe hypoxia occurs. And note that it's during REM sleep. All these REM sleep episodes are accompanied by hypoxia and by severe obstructive apneas. Okay, remember, REM sleep is characterized by a neuromuscular blockade of skeletal muscles aside from the diaphragm and extraocular muscles, and this includes the muscles surrounding the upper airway that, when they contract, tend to open the airway. Charles Dickens actually described this phenomenon extremely well in his Pickwick Papers in 1836. He said everyone was excited except the fat boy, and he slept as soundly as if the roaring of cannon were his ordinary lullaby. This actually is a true example of a patient that was seen many, many years ago, and I couldn't have set this up any better. His t-shirt says, "I used to hate myself in the morning," and then it says, "Now I sleep until noon." Well, he slept all the time. So this is very severe obstructive sleep apnea associated with profound excessive daytime sleepiness due to sleep fragmentation. So obstructive sleep apnea is repetitive episodes of complete inspiratory upper airway, that's extrathoracic obstruction, during sleep. There's a cessation of airflow at the nose and mouth with continued respiratory effort. There can also be repetitive or persistent partial upper airway obstruction without apnea that may result in hypoxia and/or hypercapnia during sleep. So this again is an example of an obstructive apnea. You can see here diaphragm contraction, paradoxical ribcage motion, and no flow. Hypopnea here is associated with a little bit of flow, less than 50% of the baseline ventilation, and then this is terminated by an arousal. So an arousal basically reestablishes upper airway skeletal muscle tone. So it will often eliminate the apneas, as you see here, but this does interrupt sleep so that one has sleep disruption and consequently sleep deprivation, and then a result is excessive daytime sleepiness. Here's an example of a published study. You can see, in this case, esophageal pressure is being measured as the index of a respiratory effort, tidal volume. So this person is breathing. You can see gene glossus EMG fades out in REM sleep here. And now we have complete airway occlusion. So despite respiratory efforts, there's no airflow. As you can see, gene glossus EMG is coming back as this person starts to wake up, reestablishes muscle control of the tongue, but falls asleep again. And this process continues and continues. So certainly this patient would be expected to have significant excessive daytime sleepiness. So obstructive sleep apnea syndrome then is a combination of a number of things. Upper airway narrowing. So in school-age children, this is often adenotonsillar hypertrophy. In infants, craniofacial abnormalities. In adolescents, obesity. Decreased upper airway tone, which could be due to decreased ventilatory drive. Upper airway reflexes or decreased arousal. And finally, increased inspiratory force. And these all combine to give you the chance, where this overlap is, of having obstructive sleep apnea. In pediatrics, obstructive sleep apnea in infants is most often due to congenital malformations. In school-age children, to adenotonsillar hypertrophy. In adolescents and adults, to obesity. Here's an example of very large tonsils. And this shows just a number of conditions in the airway that could potentially cause airway narrowing and predispose to obstructive apnea. So enlarged tonsils and adenoids here. In school-age children, fat deposition in the upper airway, in the oropharynx, hypopharynx, in adults who are somewhat obese, and enlarged tongue, and some syndromes, nasal obstruction for a variety of reasons. Notably, bad nasal allergies can do this. Jaw malformations, obesity. So a number of things can affect the upper airway anatomically to cause obstructive or predispose to obstructive sleep apnea. Cause and treatment, congenital malformations in infants. Oftentimes it's going to be craniofacial surgery or perhaps positive airway pressure. Adenotonsillar hypertrophy, most commonly adenotonsillectomy will solve that problem. In obesity in adolescents, weight loss, although easier said than done, positive airway pressure. And then obstructive apnea due to CNS depressants or neuromuscular diseases, decreased upper airway tone, and decreasing the inspiratory force can often help that. So positive pressure for obstructive sleep apnea, basically in the normal situation, inspiration, remember you have to generate a large negative intra-airway pressure so that pressure inside the airway is less than outside and you get dynamic compression. If you use CPAP, basically you're going to use a pneumatic splint. You're going to provide positive pressure in the airway, which is going to help to keep the airway open even during inspiration. Shown here, an inspiration with airway obstruction, you can see no flow, and then positive airway pressure basically is going to provide pressure here, which keeps the airway open during inspiration. These are a variety of continuous positive airway pressure or positive airway pressure masks, which can be used for children, in some cases even fairly small children, although this clearly is more difficult to do in infants. In the absence of upper airway muscle tone, can decreasing inspiratory force improve obstructive apneas? This is not something that's often thought of as a modality for obstructive sleep apnea therapy, but it's one that one could consider. Annie Wong was a medical student who worked with us 2013 2017. And so remember that we've talked about neurologic processes, a sensory input, integrator, and motor output, and that these are least robust during REM sleep. And in the upper airway, remember during wakefulness, the synchronous messages to diaphragm contraction are most robust when you're awake. A little bit less so in non-REM sleep, but quite a bit so in REM sleep. We have used a therapeutic technique called diaphragm pacing. This is a technique that provides ventilatory support for children with some rare types of respiratory control disorders, such as congenital central hypoventilation syndrome. Now, in this case, the breath is generated by diaphragm pacing, and the diaphragm pacing basically stimulates the phrenic nerve so that there's only a pathway in this direction. There is no synchronous activity of the respiratory center, and consequently no synchronous upper airway muscle activity or intercostal muscle activity. So what happens to these kids? Do they have obstructive apnea? Remember that maintaining upper airway patency does require upper airway skeletal muscle tone. So if this is absent because there's no synchronous contraction, what are our options? So one could do an endotonsillectomy or treat nasal allergies to improve airway size. One could not use central nervous system depressants to try to preserve upper airway skeletal muscle tone, or one could modify inspiratory force by decreasing on the diaphragm pacer, for example, the tidal volume setting, or increasing the inspiratory time. And in fact, that's what Annie Wong did. So you can see here that all she did in patients with diaphragm pacers without a tracheostomy is to decrease the tidal volume setting. So we decreased the inspiratory force. And as you can see, apnea-hypopnea index went down considerably, O2 saturation improved, and end-tidal carbon monoxide tension went down. Decreasing inspiratory force basically then resulted in all of these. So basically, what we were doing was decreasing the inspiratory force, and that therefore tended to open the upper airway. Obstructive sleep apnea then is usually treated by increasing the size of the upper airway. The contribution of inspiratory force is often forgotten. With decreased upper airway skeletal muscle tone, decreased inspiratory force can also improve obstructive apnea. What about supplemental oxygen for the treatment of obstructive apnea syndrome? So if obstructive sleep apnea patients are hypoxic and hypercapnic, adding supplemental oxygen may decrease ventilation by decreasing hypoxic drive. Some clinicians believe that supplemental oxygen is contraindicated in obstructive sleep apnea. So the question arises, is supplemental oxygen a safe treatment for children with obstructive sleep apnea syndrome? Supplemental oxygen will improve oxygenation, but will it reduce obstructive apneas? Gabriel Al-Hadaf, who was a postdoctoral fellow here 1992 to 1996, performed a study using oxygen for the treatment of obstructive sleep apnea syndrome. He studied 16 children. Mean age was 4. The age range was 1.8 to almost 11. Slight male preponderance. Weight percentile was not bad. BMI, also not bad. And BMI range, there were some in the obese category. So in the protocol, the subjects performed 2 overnight polysomnograms. First night was performed breathing room air the entire night. The second night was breathing supplemental oxygen. And supplemental oxygen was titrated to achieve O2 saturations greater than 95% during the first hour. And after that, that supplemental oxygen level was used for the remainder of the night. And the supplemental oxygen values in the study actually used range from 1/4 to 1.5 liters per minute. Here you can see a number of parameters on room air in blue and in supplemental oxygen on red. So arterial oxygen saturation, average obviously improved, and the lowest saturation, again, also improved fairly dramatically. The duration of supplemental oxygen less than 90% also improved, that is, it decreased fairly dramatically. End-tidal CO2 actually did not change, and the highest end-tidal CO2 did not change. And the time spent at CO2 greater than 45 torr did not change. So what this showed was that supplemental oxygen improved oxygenation, but had no effect on depressing ventilation. With respect to apneas, these were the results. Now, I want to remind you that this study was performed at a time when the definition of obstructive apnea was simply a cessation of airflow. It did not, the definition did not include a desaturation. So we're only looking at events here. And so hypopnea density, which is the time spent in apneas, decreased dramatically on supplemental oxygen. The apnea index, which is events per hour, decreased dramatically on supplemental oxygen. And the obstructive apnea index decreased significantly, but not quite as dramatically as the other two. Obstructive apnea duration didn't change much, but the paradoxical breathing as a percent of sleep time was basically halved or less than half, and the central apnea index did not change. So at the time of this study, as a reminder, desaturation was not part of the definition of obstructive apnea. So supplemental oxygen improved oxygenation in obstructive apnea without causing hypoventilation. So supplemental oxygen reduces obstructive apneas and hypopneas, the actual events. How does supplemental oxygen reduce obstructive apneas and hypopneas? It could either be by reducing loop gain of respiratory control, breathing is stabilized, and apneas are less likely to occur. We discussed loop gain earlier. The other possibility is that by inhibiting peripheral chemoreceptor drive, supplemental oxygen may decrease inspiratory force, thereby reducing obstructive events. So again, maintaining upper airway patency, we have three things that we can use at our disposal. Trying to improve airway size, trying to improve upper airway skeletal muscle tone, or in this case, trying to reduce inspiratory force so that the airway tends to remain open longer, reducing obstructive apneas. What about respiratory control in obstructive sleep apnea? So recall this is the ventilatory control. We have chemoreceptors, integrators, and motor output. And remember that sleep decreases ventilatory control. So the question is, why do some children with abdominal tonsillar hypertrophy have obstructive sleep apnea, but most do not? Do they have decreased central drive such that they cannot overcome the increased respiratory load? Or do they have increased central drive, which increases inspiratory force? So Carol Marcus was a fellow in pediatric pulmonology in 1987 and 1991. And she studied 20 children with obstructive sleep apnea syndrome and 19 controls. As you can see, the mean ages or the age ranges were comparable, roughly 50% males in each group. The weights were comparable, BMIs were almost identical, and body surface area almost identical. Whenever performing tests on respiratory control, you first want to be sure that pulmonary mechanics are normal, so that if you find a difference, it's not due to differences in pulmonary mechanics. And you can see here that these values for lung volumes, maximum inspiratory flow rates, were all in the normal range. And what's shown here is percent predicted values. And you can see there really was no difference between the two groups in any lung function. So therefore, we could proceed with ventilatory control tests which measure ventilation. So these are the polysomnogram values. Total sleep time in hours, very similar. Apnea-hypopnea index elevated in the children, actually in the severe range, obviously absent in controls. Duration of obstructive apneas as a percent of sleep time, almost 3% in obstructive apnea, 0 in controls. Peak end-tidal CO2 was 54 in obstructive apnea, 46 in controls. Duration of CO2 greater than 45 was 50% essentially in obstructive apnea, 8% in controls. Lowest SAT was 83 in apnea, 96 in controls. And duration of SAT less than 90% was about 3% of total sleep time in obstructive apnea and 0 in controls. This represents an example of a ventilatory response to CO2. Recall that minute ventilation is plotted against end-tidal CO2, and you get a tight linear correlation. In this and subsequent slides, OSAS is in red, controls are in blue. So the peak PCO2, not significantly different. The slope of minute ventilation versus CO2, not significantly different. And the correlation coefficient of minute ventilation against CO2, not significantly different. In order to correct for body size, minute ventilation was divided by body surface area. And again, this was not significantly different for ventilatory response to CO2. VTTI, recall the mean inspiratory flow rate. Mean inspiratory flow rate is a more sensitive measure of ventilatory control, not different between OSAS and controls, and the correlation coefficient for VTTI, not different between the two groups. This shows all the data. You can see individual data and the means here, and I think you can see that there is no difference in hypercapnic ventilatory response, in this case divided by body surface area, between OSAS and controls. She also studied rebreathing ventilatory responses to hypoxia, and this shows a normal response where ventilation should increase as saturation falls in a linear fashion, which is a tight linear correlation. Again, the same group, lowest saturation was not significantly different. Because the normal hypoxic ventilatory response is negative, it's shown this way, but no significant difference here in ventilation versus saturation, and no difference here in ventilation versus saturation correlation. Normalized for size, ventilation divided by body surface area, no difference in the ventilatory response. Using VTTI versus saturation, no difference. And here are the values. Again, you can see really no difference. Individual values plus the means. So children with obstructive sleep apnea have normal ventilatory responses to hypercapnia and hypoxia. Abnormal respiratory drive, therefore, plays little, if any, role in the pathogenesis of obstructive sleep apnea. But hypoxic and hypercapnic ventilatory responses were measured as a gradually increasing stimulus using the rebreathing ventilatory response model. But obstructive sleep apnea does not present a gradually increasing stimulus to breathing. Obstructive sleep apnea is repeated brief apneas, which may present brief repeated bouts of hypoxia and hypercapnia. Is ventilatory response to repeated brief events more relevant to obstructive sleep apnea syndrome? So to define the normal ventilatory response to repeated short hypercapnias, Dr. Zoll presented normal individuals with a series of short 2-minute hypercapnic challenges separated by 5-minute rests, breathing room air. The fraction of inspired CO2 was 5% during the challenges, which is a PI CO2 of 40. 10 healthy control subjects were studied, aged 12 to 39. This is the study design, so 5-minute rest, 2-minute challenge, and you can see up to 6 challenges. So this was his group, mean age 28, range 12 to 38, 70% males, weight, height, and they were all non-smokers. Again, pulmonary function testing was normal in this group, suggesting that pulmonary mechanics did not limit the test. And the rebreathing ventilatory response to CO2 was also in the normal range. So they had normal rebreathing ventilatory responses. The question is, do they have a different response to repeated hypercapnic challenges? So this shows inspiratory time, expiratory time, respiratory rate, which is the reciprocal of T-tote, and tidal volume before the hypercapnic challenge, during, and after. And I think you can see that tidal volume doubled, respiratory rate increased. And that was largely due to a decrease in expiratory time. So during the challenge, there was obviously the increase compared to before or after. Minute ventilation doubled during the challenge. Entitled CO2 by design increased. The duty cycle, TI over T-tote, did increase slightly, but the mean inspiratory flow rate doubled or more than doubled during the hypercapnic challenge compared to before or after. This kind of plots CO2 during the rest and during the challenges. By design, these are pretty similar. This is the duty cycle, TI over T-tote. That is the amount of time the diaphragm is contracting. And you can see that it tended to fall during the peak of each hypercapnic challenge. Minute ventilation actually tended to increase a little bit, as shown here. Tidal volume increased and respiratory rate fell. VTTI, that is the inspiratory flow rate, also increased with increasing challenges. So if we look at minute ventilation, this is with 5 minutes of rest are the dark circles. Open circles are with 15 minutes of rest. So you see minute ventilation is preserved. Respiratory rate, maybe a little bit of a different response there. End-tidal CO2, pretty much the same. Tidal volume increased with 5-second rest, but not with 15-second rest. So in normal adults, during repeated short hypercapnic challenges, tidal volume increases and respiratory rate decreases. A similar minute ventilation is achieved. However, increasing the mean inspiratory flow rate is required to maintain that constant minute ventilation. So the speculation is that intermittent hypercapnia modifies central controller gain. Obstructive sleep apnea presents the patients with short repeated challenges, which may include hypercapnia. Normal children increase ventilatory central drive, that is VTTI, with repeated CO2 challenges. Do children with obstructive sleep apnea have a similar ventilatory response to hypercapnic challenges? And if not, is this contributory to the cause of their obstructive sleep apnea? So here are controls, children in this case, obstructive sleep apnea. You can see age is comparable, age range comparable, percent males about the same, weights and BMI are comparable. Again, lung function, to be sure that one can use lung function to measure ventilatory responses in the obstructive sleep apnea. They're all in the normal range. All right. Controls, likewise. The polysomnogram data, comparable sleep time for obstructive apnea controls, the obstructive apnea-hypopnea index elevated in obstructive apnea, 0 in controls. Peak CO2 62 in obstructive sleep apnea, 46 in controls. Duration of CO2 greater than 45% of total sleep time, 18%, 2%. Lowest SAT, 71, 92. Duration of SAT less than 90, 8% in OSAS and 0 in controls. So repeated short hypercapnic challenges increase tidal volume, decrease respiratory rate, increase minute ventilation, and increase VTTI in normal children. But these responses are absent in obstructive sleep apnea. However, normal responses occur after surgical correction of obstructive sleep apnea. So hypercapnia increases ventilation, which requires an increase in inspiratory airway pressure. In obstructive sleep apnea, this may cause worse obstructive apnea. So a robust hypercapnic ventilatory response would be counterproductive. Thus, loss of the normal ventilatory response to repeated short hypercapnia may reduce obstructive sleep apnea. So again, we have a situation where potentially decreasing the ventilatory response to repeated hypercapnia decreases the inspiratory force and thereby can keep the upper airway more open. So it's an adaptive response, if you will, to obstructive apnea. So let's summarize the effects of sleep on breathing. What have we learned? So sleep decreases ventilatory control during sleep. Right? So remember, central perfume receptors mediate through a ventilatory controller, and this presumably is where sleep mediates to decrease the ventilatory response, decreasing the motor response. Sleep depresses breathing. Nobody breathes as well as they do while they're awake. In non-REM sleep, breathing is controlled by the automatic system. There's mild hypoxia and hypercapnia compared to wakefulness. Breathing is tightly related to blood gases, and timing and amplitude of breathing are regular. In REM sleep, breathing is controlled by the behavioral system. There is marked hypoxia and hypercapnia compared to wakefulness. Breathing is not regulated by blood gases. Timing and amplitude of breathing are irregular. Thus, there is decreased skeletal muscle tone, except in the extraocular muscles in the diaphragm. And respiratory disorders often present first during sleep. BPD patients have clinically unsuspected hypoxia during sleep and feeding. However, they do not tolerate hypoxia, often having apnea and bradycardia. REM sleep causes chest wall instability, which decreases lung volume and increases work of breathing. These can result in respiratory failure in infants. Central apnea has no respiratory effort, won't breathe. Obstructive apnea has upper airway occlusion with respiratory effort, can't breathe. Upper airway patency during sleep depends on increased size, increased skeletal muscle tone, and decreased inspiratory force. Upper airway collapse during sleep depends on decreased size, decreased skeletal muscle tone, and increased inspiratory force during sleep. Decreasing inspiratory force can improve obstructive apneas. Children with obstructive sleep apnea syndrome have normal hypoxic and hypercapnic ventilatory responses, but ventilatory responses to repeated CO2 challenges are decreased in obstructive apnea. This may decrease inspiratory force, thereby improving obstructive apneas. In summary, nobody breathes as well asleep while they do awake. Thus, respiratory disorders often present first during sleep. And this is why pulmonologists use sleep studies so frequently in their patients. Next time, we will talk about exercise physiology, the first part. Our thanks again to our director-producer, Dr. Kathleen Lewinter, and thank you so much for joining me for the great adventure, Pediatric Pulmonary Physiology.